All right, don't cringe, don't moan. We're going to talk about electrolytes. And it's actually, we get to do the fun part of electrolytes. The nephrologists and the internists get to do all the hard part, the kind of boring part. We get to do the really fun part when it comes to electrolytes. And just a little bit of my background, the reason I got into all of this is I started out in internal medicine. And I did a full residency in internal medicine at UC San Francisco these many years ago. And about halfway through that residency, realized I'd made a gigantic mistake as far as what to do with my life, like gigantic. I was $250,000 in debt and was doing the totally wrong thing. Like, you can't get much lower than that, actually, in life. It's like I was really bummed out. But fortunately, what I ended up doing was tripping. I did my residency at UC San Francisco, and I used to have a crying stairwell. When I was totally stressed out, I had a stairwell. I'd go up there and cry. So it was a crying stairwell in the residency program there. And I was up in it was this little dark stairwell, and I was having a little pity party for myself and crying and crying and crying. And the door above me opened, and I heard this coming down the stairs. And before I had a chance to move from my perch sitting there on the stairs, this person whipped around, tripped over me, and went all the way to the bottom of that thing of stairs. I'm thinking, okay, $250,000 in debt, wrong specialty, murderous, just killed somebody. And so I went rushing down to the bottom of the stairs, and the person got up and brushed himself off, and I was like, are you okay? Are you okay? And he said, no, I'm fine. And then he looked at me with my mascara-stained face, all teary and weepy, and he said, are you okay? And I said, no, I'm not okay at all. And see, I said, I'm in debt and I'm doing the wrong thing. And he said, come downstairs with me. Turns out it was the chair of emergency medicine at UC San Francisco. And he took me in his office and he said, you just rotated through the department. You seem to really like it. Did you ever think of switching? So in 20 minutes, I went from being a murderess in a ton of debt to going into a specialty that I absolutely passionately adore. So I did a second residency in EM. And so what's happened with that dual residency training is I kind of end up niched into doing a lot of the teaching on sort of the the internal medicine related stuff. But I have to tell you that the stuff that's internal medicine related that we see in the ER is so much fun. We get to do the fun part of it. We'll talk about it with endocrine. We get to do really the fun part of this internal medicine stuff and then punt it to people that take care of the long-term stuff. So let's talk about electrolytes, because we get to take care of the fun part. And a lot of what we do with electrolytes, I just have to say before we start, is do no harm. We can do a lot of harm, particularly with one of the electrolytes, if we do things wrong. So what I'm going to do is we're going to walk through the major electrolyte disorders that we see in the ER and how to approach them. But the main thing is, remember, do no harm. So we know that our bodies are a sort of a mishmash of chemicals, cations and anions that basically all swim around together and make your membranes depolarize and basically make your muscles work, and all of this stuff functions because you have this balance of sort of sodium and potassium, sort of chloride, and there's some bicarb. It's pretty great. It's a pretty wonderful soup that you happen to be made up of all of these different kinds of chemicals, the electrolytes themselves. But if they get out of whack, they can cause some significant trouble. So let's start with salt, because salt is an extraordinarily important part of your body. When it comes to salt, sodium, we can do a ton of harm. So what is crucially important is to first do no harm. Don't ever, I'm going to liken back to what I said before, never ever treat just a number. Always treat the clinical scenario for that individual patient. Never ever ever go crazy with just a number, because there are certain areas where we can really hurt people, and this is one in particular. So treat the patient, not the number, as far as this is concerned, and it makes a difference with sodium, fast versus slow. So if somebody's sodium is really high or really low, but it took a long time to get there, that person's body's had time to kind of adjust and tweak things and let other electrolytes kind of balance out. If it did it overnight, though, or if it did it in a matter of hours, so for instance, if one of the local treatments for pediatric diarrhea in our local sort of community, it's a cultural thing, is to give basically dilute tea as the fluid replacement for these babies with lots and lots of sort of rotavirus kind of diarrhea. Well, what you're doing is losing a lot of fluid, that baby is getting just free water as what they're getting as far as what they take in, and that baby can get hyponatremic really fast. That makes a difference. Fast versus slow matters. So we'll talk about that in a second, but remember, fast versus slow, especially when it comes to sodium, and do no harm. So let's start with high sodium, hypernatremia. I'll tell you, it is almost impossible to get hypernatremic based on intaking too much salt. I don't care how much soy sauce you add to your sushi. You're just not going to take in enough salt. Most people are hypernatremic because they get dry. They become a human salt lick. They get really, really dry. So most hypernatremia Takes a while to get there. The classic presentation is the nursing home person that just didn't get watered enough. They don't get out of bed. They need to get brought water or water through their G-tube, and they just don't get watered enough. And that usually takes time to get hypernatremic. So it's almost always a lack of water. It is rarely, if ever, a fluid loss deal. It can be, but it's usually just a lack of intake. It's usually just a lack of intake. And a normal person, when you get dry, gets thirsty. Right? So a normal person would go ahead and treat themselves. They would drink water. So the people that can't do that are the people at risk for hypernatremia. It makes total sense. So it's the bedbound person. It's the child that can't walk or get themselves to water or express themselves that they're thirsty. It's the person that has a little bit of mental disorder where they just are wacky and they don't know to drink or they don't express the need for water. So it tends to be people who either can't get to water or can't express the idea of thirst. The other thing to know is extreme symptoms, things like seizures and coma, don't happen at a sodium of 150 or 155. In fact, they're seen usually at sodiums of 160 or higher. So they have to be really, really salty to get to the point where they actually have symptoms that would present to us as an emergent problem, something we need to emergently do something about. Short of that, your sodium is 152 or 155. You may feel lethargic. You may feel weak. You're irritable. You feel some nausea. The symptoms are pretty nonspecific, but they also aren't urgent enough for you to go berserk fixing it right now. Fixing right now is seizures and coma. That you basically need to fix right now. Otherwise, no. And how rapidly it got there? No, it's usually a long time. It's really hard to get there fast. So it's virtually always a chronic disorder when somebody's hypernatremic. If a person can drink, so if you can bring them water to drink, let them. So that your physiology is brilliant. The human body is an amazing thing. And your physiology tells you, your thirst center says drink more water, and people will drink what they need to. If they can't though, so if they can't sort of treat themselves, you're gonna need to treat them with some basically water of some sort. Now think about it. If I have, say the highest sodium I've ever seen in a living human being is 178. If I give that person with a sodium of 178, this just happened actually, normal saline. Normal saline is a sodium of 154. It is hyponatremic to that person. Especially if they're dry, giving them a 154 milliequivalent sodium sort of bolus is hyponatremic to them and a volume repleter. So it kind of gives both things. So you basically will need to replete them, at least up to a normal blood pressure if they're hypotensive, but you don't have to go nutty. And you want to bring it down enough that they're not seizing or in a coma. But once you've got them down some and their symptoms are better, you're going to slow down your correction rate. And you can calculate this. Get out your smartphone and you'll calculate the free water deficit. And it'll basically teach you it'll show you how much you need to give and over what amount of time. But the key is don't correct the number. Just the number. If the patient's seizing or comatose, bring it down, use normal saline that's actually dilute enough, and then go ahead and replete them with free water over time. No hurry on that. I'll tell you, we don't see that often, and honestly, we don't have to treat that aggressively virtually ever. It's really, really uncommon to see hypernatremia to the point of needing urgent correction. Basically, giving some water is fine. Hyponatremia is extraordinarily common, and you can really do bad things to people if you address this thing wrong. So, let's say the lab calls you and says, we have a critical value, the sodium is 122. If the sodium is low, the first step you will always do, low sodium, the first thing you're going to do is look for pseudohyponatremia. And the first thing you're going to look at when that sodium is low is you're going to check the glucose. Instantly, I want a synapse to be completely cemented in your brain that if a sodium is low, immediately move your eyes down to the glucose column and see what that glucose column shows. So what you're going to do is you're going to correct the serum sodium. There's a formula for that. There are actually two. If you have MD Calc, which I totally love, wish I dreamed of it. If you have MD Calc, go ahead and plug in the numbers. There are two versions of the formula. Honestly, it's not that humongously different, the correction factor, but the key is what you're going to find is a lot of those hyponatremic patients, when you correct for their sodium or for their glucose, aren't hyponatremic after all. Okay, so they're not after all. And there are a few other things that will also make them pseudo-hyponatremic, meaning they're not really hyponatremic. It's just that they have a lot of lipids in their system. So when that blood gets drawn and it looks like fat in their serum, that's somebody who they may have pseudo-hyponatremia, or they have a super elevated bili, or they have a history of blood dyscrasias. Those can do it as well, but the biggest actor in this is sugar. So low sodium, first thing you do, look at the sugar and correct the serum sodium. Now, If it's still low when you've corrected it, now you have to address that. But you address it based on symptoms. You don't address it based on the number per se. So, if somebody comes in, seizing or comatose, what you're going to do is take care. You're not going to know their sodium is low to start. You're going to do your usual seizing, comatose, addressing the patient. If you find another cause, they're seizing or comatose because they have a big brain bleed, what you're going to do is fix that brain bleed. You're going to take care of whatever is the underlying other cause. However, if there's not another reason that they're seizing and comatose and their sodium is low, now you need to fix that seizing or fix that coma now. And it is where you are on purpose going to pull out 3% saline. Yeah, we use it now in head trauma all the time. You're going to pull this out on purpose to start to fix that low sodium that's causing them to seize. The dosing is basically 100 cc's and you do it 3 times in a row, except you're smart people. So go ahead and hang that 3% and go ahead and let 100 cc's of that run in the patient. Okay, our goal here is to stop seizing or wake up, become less comatose. That's our goal. So 100 cc's is going in, and now I'm going to go back and I'm going to figure out, was this something that was quick? If it was a fast onset, so this is that baby who was given dilute tea for their fluid replacement, who's gotten a really low sodium over a matter of just several hours to a day. That kid, I'm going to go ahead and give all 3 doses, boom. I'm going to basically replete them right away. However, if that person came on over time, this is somebody who's been on a diuretic for a long time, was just given an additional medicine of Lasix and got their sodium really, really low by losing it all through their urine, and now they're seizing or comatose, that took a little longer to get there. Okay, that actually took a little longer to get there. I'm going to be a little more careful. And again, your goal period in this is you try not to correct more than 0.5 to 1 milliequivalent per liter per hour. So they start at, say 118, and 10 hours later, you're going to want them to be a maximum of that, 10 higher than that, 128. You're going to want to go much higher than that. And your goal, honestly, isn't a number. Your goal is symptom improvement. So if I give that first 100 cc's at 3% saline and my seizing patient stops seizing, or my comatose patient starts to wake up, I'm going to back off and slow down. I'm going to not go so wildly crazy. And I'll tell you this, once you get to a sodium of 125, so say they start at 118 or 112 or 110, you get them up to 125, they should wake up or stop seizing, and if they don't, rethink your diagnosis. Go back and rethink it. It's like, whoa, at 125, no one should be seizing or comatose. Is there something else causing this person to be seizing and comatose that's not related to this low sodium in and of itself? So don't correct too fast, and correct really only till the symptoms go away, and then you can back off and do it more slowly. Okay, that's what you're really aiming for. Now, if I had my internal medicine hat on, what I would do at the point of having somebody who's hyponatremic is I would go all kind of crazy with calculating things like phenas and getting urinosms and all this kind of jazz. If you do that as an internal emergency medicine person, I will slap you. I will slap you silly. Because what you're going to do is be smarter. Okay, you're going to be more immediately sort of agile in your thoughts because you're going to base it on the patient's clinical history. What you're looking for here is, I'm hyponatremic. And hyponatremia comes in 3 flavors. It comes in, I have too little volume, I have just enough volume, I have too much volume. So if I am hyponatremic and I have too much volume on board, like let's say cirrhosis or congestive heart failure, that person is one kind of way to treat. If I'm somebody who's super hypovolemic, I don't have enough volume and I'm hyponatremic, say a diuretic, or lots and lots of GI sort of losses, that's another, so GI and renals, that's this category. And there's no, my volume is fine, it's just my sodium is low. That's a third category. And you're going to base, you know this. You're examining the patient, you're talking to them. So somebody who basically is hypovolemic, that's somebody who basically has renal losses or kidney or extra like GI losses. That's the diuretic person. And that's the one we see the most of, to be frank. You see the person whose sodium comes back at 124, they've been on hydrochlorothiazide forever and a day. It's kind of a random finding. It's like, wow, wasn't expecting that. They're not symptomatic, got to fix it over time, don't have to hurry. If they're euvolemic, so I have actually, my volume is just fine, but my sodium today is 122, I need to figure that out. The biggest area of that is SIADH. That's an inappropriate, basically SIADH, syndrome of inappropriate antidiuretic hormone. And that's related to certain kinds of conditions like cancers. So it tends to be brain problems, lung problems, and cancers tend to cause that. And then the final one over here is I have too much volume. I'm volume overload and hyponatremic. That person, you know that person. It's the cirrhotic. That's the person with renal failure who has lots of fluid overload, the congestive heart failure patient. So you can clinically figure out what to do with these people because the treatments are based on what their volume status is. So once they've stopped seizing, and they're not comatose, or if they never get there, you're not going to go crazy. You're going to basically, on purpose, make a decision on what you do. So if they're not seizing, not comatose, they're just basically, the sodium comes back low. They're a little lethargic. They just don't feel so great. What you're going to do is if there's too much fluid on board, cirrhotic congestive heart failure, you're just not going to give them any more. Fluid restriction for that person usually is enough. And you may need to give a little bit of diuretic just to get some of the fluid out. You still run a risk of getting more sodium out with that, but you get the fluid out. Usually loop diuretics, Lasix, or furosemide's the one for that. But in general, you fluid restrict those people. If they're not comatose, there's no hurry here. There's no hurry to get that thing up to normal. If they're euvolemic, that's that SIADH kind of person. If they need fluid, or excuse me, if they're hypovolemic, that person needs fluid. And again, remember, you can go ahead and give a little bit to tank them up, but you don't have to go nutty with this. Okay, you don't have to correct the sodium. You're just basically filling their tank. You don't have to go nutty with this. And then if their fluid is just right, you're going to fluid restrict those until we figure out why. Why do they have SAADH? Why is it that this person is actually has normal volume but has a low sodium? The key to this is not to do harm. So your disposition is you're going to admit people who are sick when they come in, so comatose, altered, etc., whose sodium is less than 120 when they come in, because to safely get that thing up to a normal range is going to take more than 24 hours. Okay, or there's another reason to admit they're sick. They're sick for whatever reason. That is when you're going to take your mouse and you're going to go over to urine osms, you're going to go over to urine sodium and urine electrolytes, not before then. Because that's how they'll use those upstairs just fine. You don't need to have those numbers to make your decision on what to do in the emergency setting for somebody who's a low sodium. And you're going to observe people if they have a sodium of about 125 or so until you can just get them up to a normal range. Now, I'll tell you why it's important. You may know why it's important not to raise their sodium too fast, too high, too quickly, not to normalize the number. There's a condition called central pontine myelinolysis. It has a new name recently, but that's basically what happens is, say I decide I'm going to be a hero, and I take my person who had a sodium to start of 118, but they're fine. They're talking to me, they're fine. And I'm going to send them upstairs with the normal sodium level. So I go crazy giving them 3% saline or giving them normal saline. I get those numbers buffed to normal before they go upstairs. I feel really good about myself. The problem is that person's central nervous system doesn't like getting that much sort of sodium back that fast. It's gotten used to having a lower sodium level. And what will happen is the myelin sheath, usually of your pons in your brain, gets destroyed. And not today while you send the patient upstairs, but tomorrow or the next day, that person ends up locked in. They're awake, they're alert, and they can't move forever. So you don't want to cause harm. So don't go crazy fixing a number. Treat the patient as is appropriate. If you want sort of a summary in words, there are 2 slides here with words. You can go ahead and sort of take a look at that. Okay, that's sodium. What about potassium? It's the other big one that we see, right? It's the other sort of electrolyte abnormality that we see. And hyperkalemia is really, really common. We had this happens all the time, right? You get a person who's sent to I love this, gets sent to the ER they get a call from their primary care office saying, you got to go to the ER right away. You have an elevated potassium. You got to go to the ER right away. We checked your labs on Tuesday. Yes, it's Friday, but go ahead and go to the ER. It happens all the time. They get random labs checked and their sodium their potassium is 5.8 or 6. And they get sent to the ER. We see this all the time. Your job as an emergency person, if somebody's potassium is elevated, first of all, if it's elevated on Tuesday and it's now Friday, first check again and see if it's still even up there. But if it's elevated, the first thing you're going to do is take out your lovely little mouse and you're going to click on EKG. Because you want to see if that elevated potassium is doing anything to the organ we really care about, which is the heart. Right? This is what's used in lethal injection capital punishment cases, is they use potassium to stop the heart. We don't want to do that in the emergency department. So what you're going to want to do is order an immediate EKG in somebody that has an elevated potassium. What you're going to look for are the changes that you see related to that. And I think of these as taking a string. So I think of my EKG with all of its little squiggles. I take a string. If I take that string and I push the ends together first, what will happen is my T wave will go nice and peaked. It's going to look, and it looks peaked. It's not a T wave that's just kind of a little bit taller and a little bit, it tends to be pretty peaked. And compare to an old one to see if it looks kind of weird to you. But it's like a T wave you don't want to sit on. It's just too peaky. And then, as my potassium gets higher and my heart gets not so happy about this, you pull that EKG out. So the first thing that happens is the PR gets longer. And then my little bump of a P wave just flattens out. And then my QRS complex gets wider. And eventually, I develop the sine wave, which is the lethal sort of end result of having your potassium be too high. I want to tell you something else, though. Anywhere in there, meaning that the EKG can be stone cold normal, you can get bradycardic as a cardiac toxicity of hyperkalemia. So I will tell you, a really good practitioner will take somebody who's called in as a bradycardic, somebody who's a symptomatic bradycardia case coming in on a run. And what they're going to do is they're going to go right to the bedside, and they're going to take this patient's sleeves, and they're going to look at the patient's arms. And they're going to be looking for hemodialysis, fistulae, or shunts. If you have symptomatic bradycardia and somebody who has a shunt on board, if you can do a point of care potassium, do it right then and there. If you don't, just give them some calcium. So if they have no other reason to have bradycardia, and you have somebody who is a dialysis patient, odds are their potassium is high, treat it. Okay, it can cause bradycardia in and of itself with none of the other peak T's, none of that other jazz. It can just do that alone. Oh, by the way, the causes of this, the most common cause of hyperkalemia is renal failure, but the other humongous group is ACE inhibitors. So you're also, not just check the shunts, you're going to ask for the meds list, and you're going to look for ACE inhibitors. Look for someone with a prill on the end of it. And that's going to be a suggestion. Lisinopril seems to be the biggest actor in this, but any prill. So look for the prills as far as causing this. Here are those EKG changes I told you about, but remember, bradycardia can be just in there, in and of itself, just bradycardia can be all they have. The treatment for us, you guys know this, right? So our first line, if that heart looks irritable, so it's that there are changes on the EKG or bradycardia I can't explain, I'm going to give calcium. Okay, my goal is to give calcium. That protects the heart. And you have a choice of gluconate or calcium chloride. Honestly, either one is fine. The key is to get calcium to the heart. So you grab it off the crash cart, grab your calcium chloride, and give them a push of that. What you'll see, if this is somebody who's symptomatic bradycardia from their missing dialysis a couple of times, is that bradycardia suddenly just goes away. Or if their QRS is wide and they've lost their P waves, you're going to watch that EKG shrink back down to normal. It's like magic. It's like magic what this will do. So calcium is really, really important if the heart is having problems. Then what you need to do is get that potassium somewhere else. Get it somewhere else. So what we do is we shift it for a while. And we shift it with that glucose-insulin combo. Insulin shoves potassium into cells. We'll talk about that again when we talk about DKA. Bicarbonate, especially if somebody's acidotic, bicarbonate will shove potassium into cells. So you can give bicarb, and inhaled adrenergics. So you give somebody inhaled beta agonist, give them inhaled albuterol. That will also drive it into cells. So all that's doing, though, is shifting it. It's not getting rid of it. It's just moving it into cells for a while. So it buys you time. Eventually, we need to eliminate them. But I will tell you, for most patients who are in the ER, the eliminator that we really need is dialysis. If it's a dialysis patient who missed dialysis, what they need is dialysis. So you will need to get the renal people in or transport the patient to where they get their dialysis, because the things on this slide are, yes, they will eventually get rid of the potassium, but I'll tell you, they don't work very fast. They don't work very fast at all. So K-Electrolyte's what we've used forever and a day. It's gotten a lot of bad press, deservedly so. It's not particularly effective. It can cause colonic necrosis, so it has some pretty significant downsides. So K-Electrolyte, although a lot of us still think about it or order it or are told to order it, it turns out it's not really a great agent for this. There are two new agents out. One's drug name is Hypocalcemia. I'll let you read that. But it's a zirconium binder as well. It's a powder that mixes up and they drink that. But that doesn't work quickly. And in fact, the product insert itself says it basically should not be used as an emergency treatment of life-threatening hyperkalemia because it doesn't work fast. It takes hours to work. It's basically meant to keep people who stay high, even despite dialysis, to bring their potassiums down. There's also another one called Veltessa, which is the drug name. This is patiromer. This is another one that basically is the same concept. It takes a little while to work. So you may be asked to order these things. Just know it's not going to be magic. And it's going to take a while to work. And your shifters that you gave earlier are eventually going to basically get metabolized, and that potassium is going to come back out. So just keep an eye on those folks. Hypokalemia is the other thing we see a ton because of so many people on diuretics. Most of our diuretics are potassium wasting drugs. The only one that isn't is spironolactone. All the rest of them, you basically pee out, spironolactone and triamphene, but you basically pee out potassium. So it's part of what you lose, sodium and potassium in the urine. So you can also lose this with GI shifts. So somebody who has GI and renal losses, they can lose this as well. And the symptoms when people get this, the main thing, honestly, is weakness. They feel kind of weak and just, which is a very non-specific finding. They can end up with ectopy. They can end up with and PVCs are pretty common actually with low potassiums. People get PVCs. Nausea, they may have some polyuria, but mainly it's just I feel lethargic and I feel a little nauseated. If they get really bad though, if they get really, really low, you cannot contract a muscle unless you have potassium. It's actually required for muscle contraction. Your sodium ATP channel works to shift things back and forth, and it allows you to make a muscle contraction. So if your potassium gets really, really low, you can end up paralyzed. The cases of this that are awesome are the cases of, my favorite case of this was a hypokalemia case where a family brought in their son, like 20-something son, and the chief complaint was, he's a lazy son of a bitch. That they literally deposited him in a chair and said he's a lazy son. And the dad said, every night he sits in front of the television set and he channel surfs and he eats ice cream every night and he just sits there and channel surfs and he won't move and he just sits there and he sits there and he won't get a job and he's just a lazy son of a bitch. And tonight, not only was he sitting in the chair and eating his ice cream, he slid out of the chair and laid on the floor. I told him to get out of that chair and he wouldn't get up. So they drag him in and the guy is sitting in the chair like this. I was like, whoa, dude. Couldn't lift an arm, couldn't lift a leg, had a potassium of 1. What he had was periodic paralysis. He got a sugar load every day by eating ice cream. His insulin released in his own body. It shoved his own potassium over excessively into his own cells, and he basically drove his own potassium down every day by eating ice cream. Awesome. You don't have to treat that, by the way. It tends to come back on its own unless they're really, really bad, like they're not breathing kind of bad. And then you can give them a little, but most of the time it'll shift right back out again. So remember that. If somebody comes in kind of weak and lethargic, check their potassium. That may be the problem. Also know that potassium has a friend, an electrolyte friend, that they are always together, and that's magnesium. The potassium and magnesium are best friends. To fix one, you have to treat the other. So even if the magnesium level is normal when you measure it, to fix a low potassium, you've got to give magnesium. So I give a little bit of magnesium, you can give a gram or two, and then give them potassium because it won't stay. So treating people, you can do it orally is fine. You don't have to do it IV. If they can't move, fine, IV. But if they're otherwise fine, go ahead and treat them orally. But no, if somebody comes in with a potassium level of 2.5 and they've been on a diuretic for a while, they are literally hundreds of milliequivalents down. It's going to take you a while to really replete that completely. A single dose isn't going to do it. So what you're going to need to do often is put those kinds of people in OBS and just let them get orally replete until their potassium's up to be a safe level. And again, remember MAG. You've got to give MAG for potassium to stay absorbed appropriately. Here's some EKG changes just for interest's sake. I'm going to switch to the last two electrolytes, and then we're going to do our Q&A session. Hypercalcemia. So this is basically, there are two reasons people get hypercalcemic. If you're lucky, it's because you're hyperparathyroid. Your parathyroid glands go crazy, you basically release calcium into your bloodstream, and you end up hypercalcemic. If you're unlucky, it's because you have a parathyroid hormone-like chemical in your body from a cancer. So we tend to see hypercalcemia primarily in cancer patients. That's the group we see this in the most. It's a little bit complicated because calcium likes to be bound to protein. Some of it floats around in your body free, and some of it's bound to protein. So to measure it completely, you need to know an albumin level as well. But when people get hypercalcemic, what tends to happen is they get lethargic, they get constipated, they get nauseated, they get dry, they just feel gross. They feel gross. And this is sort of the thing I was taught. It was mostly the bones, the moans, the toxic, all this. So they get painful bones, basically, because it's leaching calcium out of their bones. They get kidney stones, they can, over time. They get constipation, so a lot of belly pain, some nausea that goes with that. And it can make them lethargic, and it actually can put them into a coma if it gets too high. So and think about it, you're a cancer patient. You're getting chemo that makes you nauseated and feel gross. You're getting opiates to treat your cancer pain, which gives you constipation. So you're going to feel lethargic and nauseated and constipated. Unless you're an astute clinician And you glance at those labs and notice, wow, that calcium is 12.8. That's too high. That's too high. And actually corrected, it's a little higher than that, because I looked at the albumin and I corrected it. It's a little higher than that. Maybe this person's symptoms aren't from their chemo and their cancer and their opiates. Maybe they're symptomatic because they're hypercalcemic. It makes you dry. It just makes you miserable, absolutely miserable. There's a heartbreaking study that looked at hypercalcemic cancer patients in the hospital, and half of them never had the calcium addressed, even though their symptoms were related to being hypercalcemic. So what you'll also see is an EKG that shows a shortened QT. So the QT may be short, and that may be a clinical sign to you that, oh, maybe what's going on here? That may be a clinical sign. Your job, if you diagnose hypercalcemia, is to water the patient. Hydrate them. So you're going to give them normal saline. That's all you need to worry about. All the other jazz, honestly, can get done later. The calcitonin can be done later. The bisphosphonates can be done later. Your job is to get that patient rehydrated. Often, they'll pee out enough of that calcium that they feel much, much better before anything more aggressive is done. Now, hypocalcemia, the most common cause of this is renal failure. My favorite case of this was a guy that was brought into triage because he said, I keep getting hand cramps. What's up with that? I keep getting hand cramps. I'm having seizures in my hands. What's up with that? Young guy, totally young guy, mid-20s, late teens, really young guy. And he was out there like this. It's like, what is happening? He's like doing this whole carpopedal spasm thing. The critical value called from the lab was a calcium of 4. He also had a phosphate of like 9 and a BU and creatinine of like 100 and something over 19. He was in raging renal failure from untreated hypertension, which was really sad. So hypocalcemia is one of the things you see in renal failure. They can get tetany, and this is the tetany you can see when they put the blood pressure cuff up. You may see that. So they may get tetany with this. And again, it's just carpopedal spasm. It's not super bad tetanic. And this you basically can treat either orally or you can treat IV. No, you don't have to go crazy with this. Okay, treating hypocalcemia, you don't have to go nutty. And in fact, if it's from renal failure and their phosphate is high, treating it too aggressively can cause them to deposit calcium in their body. So you're going to basically just get on the horn in that kind of person, that renal failure patient, and get them dialyzed. All right, last two things. Hypomagnesemia, really, really common, not that commonly treated for us. And the group we see this in mainly is the people that don't eat well, so people that are poorly nourished, and alcoholics. Alcoholics tend to be hypomagnesiemic. So the symptoms here are also very vague. You can measure it on your lab. If it's definitely low on lab, go ahead and treat it. And remember, anybody whose K is low, you're also going to treat even if their MAG is normal. Oral therapy is absolutely fine. Okay, you don't have to go crazy, give me an IV. Oral therapy is fine. And then hypermag we only see in renal failure. It's hardly ever seen anywhere other than renal failure. So it is really, really rare. So that's not something you need to worry about. So remember, when it comes to sodium, only treat the patient, not the number. Do no harm. Okay, and when it comes to low sodium, you'll figure out what their volume status is and you're an expert. Hyperkalemia, it's the heart you worry about the most. Hypokalemia, you don't have to go crazy treating. You can do orally, just as a matter they've got a lot of volume deplete. The hypercalcemia, think about it, somebody's lethargic and constipated, especially if they're a cancer patient, treat that with IV fluids. All the rest of it's pretty straightforward. And don't forget, when you're repleting potassium, always replete magnesium too. There's the EKGs if you're interested, and it's going to be Q&A time. Thank you.